welcome to the Studio DOHC podcast. We're happy to have you join us today. My name is Dr. Renzo Corzano, and I'm here with Dr. James Adams. We are actually both primary care physicians here at Desert Oasis. In this episode, we'll be discussing men's health. We will also be exploring a variety of topics to address within the context of Pride Month. We felt it was vital to shed light on the specific health challenges faced by men and address them head on. So basically, throughout this episode, we're going to be emphasizing the significance of things such as prevention, early detection, and overall well-being, as well as some specific topics for our LGBTQ patients. All right, James, so let's talk about men's health during Pride Month. So for me personally, it would be trying to destigmatize, sexual activity and, all the stuff that people engage in, and just kind of, promote this awareness that it's okay and it should be okay, and it should be expected for a patient to have these open discussions with their providers and actually, feel like they're going to be screened appropriately. And, something that has come up between James and I, like just in having these conversations that we have, is basically things like, you'll go see someone at place A, and you basically just say something like, I just need to get screened for an STD. And nobody really tries to ask you what kind of sexual activity you've gotten into or you've engaged in, right? And so if you don't really know as a provider what your patients are doing, then, or you don't know how to ask those questions, I feel like you can't really help them.
I absolutely agree with what you just said about stigma and normalizing conversations about sexual histories and talking about sex. I think it's absolutely very important to talk to patients about what exactly they do, what practices they participate in, so that you know how to screen them.
Right. And on top of that, too, it's also about teaching your patients who have tested positive how to deliver those news to their sexual partners, right? Because I feel like a lot of the times our patients need a little bit of encouragement because you have to disclose so that, you continue treatment going.
Yeah, and absolutely. And also being able to treat their partners.
Yes.
If they have multiple partners, or if they, it's just nice to be able to offer that treatment to partners.
Yes.
And we should be doing that, actually. It's now a CDC guideline to be offering partners treatment.
Very true.
Which can be challenging at times because sometimes that person may not be your patient, and
right.
But it's important for us to do the legwork.
Yes.
and to go the extra mile to getting the partner treated, or else you're going to just have our patient come back with another STD.
Right. Absolutely.
And not to mention, it's very important to follow it up with follow-up testing. Yes. So if someone comes in positive for gonorrhea, chlamydia, or syphilis, it's important to test them probably 3 months later.
How do you feel about the U equals U?
Yeah. So U equals U is undetectable equals untransmittable or untransmissible. Basically, it's referring to your HIV positive patients to ensure that they're getting the care that they need, the appropriate follow-ups to get them to undetectable with HIV therapy. We have so many medication options for our HIV patients now that they're really we should really be striving to get all of our HIV patients to undetectable so that it decreases the risk of transmission of HIV. Right. Because there's no way for a patient who is HIV positive, who has an undetectable viral load, to pass on their virus to someone who is HIV negative. And that's been well established in studies.
Yes. It's amazing how far it's come, right?
Yeah.
With PEP and DoxyPEP, and
yep.
It's great. Yeah, it's really good.
We sometimes call it HIV treatment as prevention.
Yes. So let's talk about DoxyPEP, actually, because I've been having a lot of patients lately come asking for this. I just had one this morning. What do you think about it? Actually, can you tell us, kind of what it is?
Sure.
Kind of so how we prescribe it?
Yeah. So DoxyPEP is a term that is basically used to signify doxycycline post-exposure prophylaxis. So doxy is just short for doxycycline, which is a common antibiotic that we've been using for years. And then post-exposure prophylaxis is the shortened acronym for that would be PEP. So DoxyPEP would be for a patient who has had condomless sex and who might be at risk of gonorrhea, of acquiring gonorrhea and chlamydia or syphilis, and doxycycline can actually prevent gonorrhea, chlamydia, and syphilis. It's actually been shown, according to the California Department of Public Health STD Control Branch, that in patients that are taking HIV pre-exposure prophylaxis or PrEP, that if they take doxy-PEP, it reduces their chances of getting syphilis by 87%, chlamydia by 88%, and gonorrhea by 55%.
That's amazing.
And in our patients living with HIV, doxy-PEP reduces syphilis by 77%, chlamydia by 75%, and gonorrhea by 57%.
Yeah.
So it's a strategy that we cannot ignore, especially in this day and age where STIs, sexually transmitted infections, are at epidemic proportions. And COVID has probably complicated that because less people were getting tested during COVID because of wanting to shelter in. So I think it's very important that we embrace all modalities of testing and treating our patients.
And preventing
STDs.
these things too. And doxy-PEP's really easy. It's only 200 milligrams of doxy, which is just 2 tablets within a day or 3 days of having, high risk, sex or, So
Absolutely.
It's great. It's really good.
Fairly low risk drug too. I mean, we can't ignore some of the side effects, which are, I wouldn't go out into the sun after taking doxycycline. You can certainly get a bad rash. We don't really know the effects of doxycycline on our gut microbiome, so we could be kind of altering our gut microbiome of bacteria. Studies haven't really been done on that yet, but due to this overwhelming data of protection against STIs in our patients at risk, we absolutely, in my opinion, have to embrace it.
I agree. We want to talk about HPV, which is, kind of a little interesting to screen in our patients. So I'll share kind of what my approach to HPV screening. So HPV is basically human papillomavirus. I think most people know it from PAPs, like female PAPs, which we screen for HPV in the cervix. But actually, in men that have sex with men, you can actually also be infected with HPV in the rectum. And so I pretty much offer HPV anal PAPs in all my men who have sex with men patients. And it's really easy. I mean, it literally takes about 5 minutes to actually do the swab. You can do it in the office. There's no special equipment required. You basically just get a swab and, you kind of just go in there and like swab really well and then just send it out for culture. And, depending on what we find, we kind of escalate from there. But something else that has come out of that and offering that service to my patients is basically, so we were actually vaccinating for HPV, and the cutoff used to be around the age of 27, I believe, right? Mm-hmm. So now that's actually been extended until the age of 45. So if I see a patient who is at risk of having HPV in the rectum, or even if they tested positive for, an anal PAP, I basically go ahead and offer the vaccination as well. So, it's another way to basically prevent something that can, harm somebody, because HPV, if it goes uncontrolled, it can lead to like rectal cancers, basically, right?
Absolutely, and I think that's amazing that you're doing that. It's an extra step to take care of our gay patients and patients who have sex basically via their anus,
right?
And it's really the only way that we can test for HPV, because we don't do oral swabs and we don't do swabs of So it's really the only way we could test for it. And there was a Sentinel study done about a year ago. Actually, today is the 1-year anniversary of the Anchor trial, which was an NIH study that showed that in patients with precancerous lesions in their anus, that treating these lesions led to a 57% decrease in anal cancer versus patients who were just actively monitored. So the study was so overwhelmingly convincing that screening patients for anal HPV and treating these lesions was so beneficial to these patients that they actually had to stop the study. And the masses haven't really caught on yet in terms of employing this into our daily practices. But as you've demonstrated, it's absolutely possible to do it. It's also important to have the resources available to treat patients with anal precancerous lesions. So we have to keep that in mind.
Yes.
And that may be something that we could be excited about developing here at Desert Oasis.
I agree. That'd be great.
We'd certainly want to talk about STD screening and how to properly screen our patients for STDs and what our patients should be doing for themselves to keep themselves safe and protected. One of the things that I would like to point out is how to properly screen patients for STDs, especially if they are gay or bisexual. We have to basically screen the area in question. So if someone is having oral sex, then we have to screen with swabbing their throats for gonorrhea and chlamydia, as well as if someone is having anal sex, we have to screen their anuses for gonorrhea and chlamydia as well. A urine for gonorrhea and chlamydia test is not screened for disease in someone's mouth or anus, and not a lot of practitioners in the community really practice keeping that in mind. So it's important that we test our patients properly.
Yes, I agree. I think there's a lot of stigma when it comes to sex. Sometimes, it's kind of seen as kind of taboo. And I found that for a lot of my patients, when we do kind of follow up after they've been, screened or tested somewhere else, you kind of question them, and then they say, oh yeah, the doctor never really asked me what kind of sexual activity I engaged in. So oftentimes, people miss like rectal gonorrhea, when you're right, if you just ask a patient kind of like what their sexual activity is, they were able to catch that. So I've seen that pretty much like a lot, actually.
Yeah,
So.
absolutely. And at a few places that I've worked out in the past, we had an old saying, if you use it, swab it.
Yes.
Although we don't really swab penises because it's a little painful, and a urine for gonorrhea and chlamydia test does screen for disease in your penis. So,
absolutely.
But it is important to have your throats and bottom swabbed if you are using those with sex without condoms.
Very true.
And I think it's also important to not abandon some historic practices that we should still be encouraging, like condom use.
Right.
Openly talking about sex with your partner. It's okay to talk about HIV status and whether or not your partner has been tested for STDs and whether or not they've been tested properly.
Right.
Along with the gonorrhea and chlamydia testing, syphilis testing, HIV, hepatitis C testing.
Yes. And hepatitis B.
Hepatitis B is very important and preventable.
Yes, very much so.
If we have a patient that is at risk of getting hepatitis B, then we should be checking whether or not they're immune to hepatitis B. And if they are not, we should be vaccinating.
Yes.
And so many times I've caught patients who were at risk of getting hepatitis B, and their provider didn't bother to check whether or not they had the protection or not.
Yeah.
Another one is hepatitis A, especially in gay men. It's important to ensure that our patients at risk are immune to hepatitis A, because that can certainly be passed on sexually.
Yes, absolutely.
So hepatitis B and A are completely preventable. Of course, hepatitis C is not preventable because there's no vaccine, but it is important to be testing our patients for hepatitis C because it's absolutely curable.
Yeah, absolutely.
And I love treating hepatitis C because it's one of the few infectious diseases that we can actually cure. And it's very gratifying when we have patients that clear their hepatitis C and stunt the progression of their liver disease.
Yes, it's very good. All right, so let's bring it back to just general men's health in general. So let's see, what do you want to start with? Prostate cancer screenings is a little controversial right now. Men.
Sure, we can jump into that, or we could go into something else and come back to it.
Okay, so let's start with just other essential screenings that we do for men. Are you using the USPSTF recommendations published?
I do.
Okay.
I do. And before we talk about general recommendations for screening, we probably should just talk about what the USPSTF recommendation A through C actually means.
Right, okay.
Because different screening modalities have different level recommendations, and it's important to know what.
And this is kind of the one that we use for primary care specifically.
Correct. Right. And USPSTF, by the way, stands for United States Preventive Services Task Force, and it is the body that we pretty much get all of our preventive and screening guidelines from. And so it's important. So let me just touch on what levels A, B, and C level recommendations mean. So a grade A level recommendation would mean that there is high certainty that there is a net benefit of the screening test. Mm-hmm. And there's high certainty that the net benefit is going to be substantial.
Right.
Whereas a grade B would be a recommendation that is based on a high certainty that the net benefit is either moderate, or with a moderate certainty that the net benefit is moderate to substantial. Right. So not quite substantial, but moderate. And a grade C level recommendation means that there is moderate certainty that the net benefit is small.
Right.
So in actuality, if we want to jump back to prostate cancer screening, so prostate cancer screening is a grade C level recommendation. So it's a very controversial topic, and depending on which doctor or expert you ask, they're going to give you a different answer of whether or not they screen for prostate disease. So personally,
your experience, exactly right.
Personally, I am a believer in prostate cancer screening. I've been practicing for 20 years, and just from my own experiences with my male patients, I've caught so many cases of prostate cancer just from a digital rectal exam and I learned so many other things from doing a digital rectal exam about a patient, that I absolutely think it's important for us to be checking prostates and screening for prostate disease with a digital rectal exam plus a PSA test.
Agreed. Yeah.
I would never do one without the other.
Right. Yes, very true. And then you also kind of take in risk factors, right? Like family history and actually race would be one of them too that you would actually think about when you do prostate cancer screenings as well.
Absolutely. I think it's very important for us to keep it patient-centered and to have that discussion with your patient before ordering the test, because you want to kind of talk about the risks and benefits of screening, because we do know that there are some risks for screening for prostate disease or prostate cancer, including provoking anxiety, diagnosing conditions that might not otherwise, which the patient would have maybe lived with for the rest of their lives, that really did not need intervention. Cost.
Yes.
And can you think of any other negatives to screening for prostate cancer?
Like an unnecessary biopsy and
unnecessary testing, pain for the patient. But the reason I still believe in it is because I have caught cancers in 50 and 60-year-olds, which were high-grade lesions that would not have been caught without testing them.
I agree.
And these patients could have died early in life, and I think dying in your 50s and 60s is just too early.
And I bet you they were probably asymptomatic, right? No blood in the urine, like nothing really like that, right?
Asymptomatic, just caught it on a digital rectal exam, a little bump on one of the sides, and happened to refer those patients to a urologist, and prostate biopsies lead to prostate cancer diagnosis, sometimes which is high grade, which is something that you really kind of want to know about.
So let's move on to more screening. Okay, so let's talk about heart disease, because it is a number one killer right now in America, basically men and women. So heart disease, very multifactorial, right? I mean, we're talking about blood pressure, we're talking about other things that can actually affect it, like, diabetes or just, elevated cholesterol levels. So how do we go about, screening our patients for all this stuff, and at what ages?
Great question. So I would say that, well, first of all, with cardiovascular disease, it's important for our patients to keep a good blood pressure. And so blood pressure screening really should probably start at around age 40.
Yes.
And if someone is earlier in life with other risk factors like obesity or diabetes, then certainly we can check their blood pressures earlier than that. But goal blood pressure, of course, should be 120/80. That's a perfect blood pressure. I typically will tolerate a blood pressure up to about 140/90, unless they have other risk factors for cardiovascular disease like diabetes or kidney disease. So it's important for our patients to come in and get checked, starting at age 40. And patients always ask me, how often should they be getting a health exam or a physical? And my personal opinion is that the yearly physical probably should start around at age 50, because 50 is kind of the magic number for other preventive screening measures like colon cancer screening, which is actually 45, and prostate cancer screening and other types of screening. So 50, I consider, the time where our men should probably be coming for their yearly annuals. And we know that it's tough to get our men into the clinics because they don't want to come to the doctor.
Right. Usually the wives that drag them in. Or the husband.
and the much feared digital rectal exam,
Right.
which is really not a big deal at all. We talk our patients through it. It takes just a couple of seconds, and it gives us very valuable information.
All right, James. Let's talk about colon cancer screening. What age?
Colon cancer screening. So this just changed recently in the last couple of years. Now we should be screening our patients at age 45, unless they have a family history of colon cancer.
Right.
Then we should probably be starting a little bit earlier. So before it was 50, now it's at 45. And personally, I think that patients should get a colonoscopy at some point in their lives.
Yes.
I know that patients don't really want to get colonoscopies.
Yes.
They really are kind of a pain in the butt. But I don't think that fecal occult blood testing is an absolute equivalent to colon cancer screening. So I think it's important that we try to encourage our patients to get colonoscopies at some point. Yes, we can use a stool testing to maybe delay the colonoscopy for 1 year if it's just a fecal occult blood test, or maybe 3 years if it's the Cologuard.
Yeah.
But I do try to encourage my patients to get
I
cancer
agree,
screening.
especially like in that 30-year window. Like I'm always like, just think about having an actual, it's gold standard, right? You go in there, you take a look and actually see what's in there, right? So
Yeah,
that's
and you're done for 10 years. If everything
Exactly.
that checks out, then you
Yes.
don't have to do another one for another
Right.
10 years. So
Very much true. And then there's also some very specific screening that we do. So lung cancer screening, right? What I find interesting is like only for men, really, is it if a man has ever smoked in their lives, they actually should have an ultrasound of their aorta, right, to check out, to rule out aneurysms. And that's between the age of 65 and 75.
yes.
And tell me about the annual low dose CT.
Yeah, so for screening of lung cancer, so we recommend screening of lung cancer for any patients who have smoked more than 20 pack years, which means a pack year history of smoking is basically if someone has smoked a pack a day over X number of years. So a 20 pack year history of smoking means that a person has smoked for 20 years at about a pack per day.
Right.
So any male who has smoked for more than 20 years should get lung cancer screening with a low dose CT scan of the lungs after age 50.
Right.
And so that should happen for all of our current smokers and anyone who has quit smoking within the past 15 years.
Absolutely.
And there's so many times where I've come across patients who have not been screened for lung cancer.
Yes.
So it's something that we should definitely keep important.
I actually put it as part of my my new patient template. I
Nice.
just put like all the screenings, and then I ask them like, ever smoked, and then it just kind of like goes into the questions and stuff that you ask. Very true.
And I don't know about you, but in terms of DEXA scanning our males,
yes.
it's a little controversial in whether or not we should be checking bone mineral density in our male patients. But I think it's important for our patients who are at risk for bone disease,
Yes.
such as patients who have taken steroids for longer periods
Right.
of time, or our HIV patients who have been on
yes.
medications that could decrease their bone mineral density,
absolutely.
or PrEP patients, who
yes.
have taken Truvada or
Right.
other medications that could lead to bone loss,
Mm-hmm. Very true.
rheumatoid arthritis, other conditions.
Yeah. Let's see. What else can we talk about? Vaccines.
Vaccines.
Controversial.
Yeah, vaccines. So this is really for all of our patients. So of course the regular vaccines, tetanus shot every 10 years, and then now it's combined with diphtheria
Yes.
and pertussis. So it's Tdap. So a Tdap about every 10 years.
And a shingles shot.
A shingle shot. I push my Shingrix vaccine for our patients over the age of 50. Shingrix is the vaccine that will prevent recurrence of the chickenpox virus into shingles, and it's a 2-shot series that we offer our patients over the age of 50 that are 2 to 6 months apart.
Do you ever tell them that they're going to have a side effect from that specific vaccine?
I do mention the possibility of fatigue the next day,
Yeah.
because I have heard it anecdotally from several patients that they just feel like they've been hit by, and it just takes 1 day of rest in the bed.
And it's weird. It's never both. It's either the first one or the second one. I have a funny story about this. So I had a friend during COVID who actually was going to go get his shingles vaccine. And I told him, I said, just so you know, it's going to be the first one or the second one that's going to get you. And once he got it, a couple of days later, he messaged me. He goes, "I'm really glad you told me that because I thought I had COVID." Because
Oh, wow.
he had like very severe myalgia from it. So
Oh, wow.
it's kind of funny.
Okay.
But I tell my patients that now all the time. I'm like, it's going to be the first one or the second one that may potentially give you some side effects.
Okay.
So,
But I think a little fatigue the next day or a little headache
totally
is
worth
better
it.
than getting a painful rash
Absolutely.
that could possibly, give you pain for the rest of your
For the
life.
rest of your life. Very much true.
And then other vaccines that are important
Pneumonia.
are pneumonia shot, of course, for anyone above the age of 65,
Yep.
and for anyone with chronic conditions, we think about giving pneumonia shots a little earlier, maybe it's starting at age 50. And then let's see, what else do we have? Hepatitis A and B vaccination is very, very important based on what we discussed about earlier. Anyone at risk of getting hepatitis A or B, anyone who's using IV drugs or having sex without condoms should think about getting their hepatitis A and B statuses checked and getting vaccinated if at risk. Let's see, what
Meningitis would be one too.
meningitis shot is very important. And when we talk about meningitis shots, we talk about meningitis A and meningitis B vaccines. So meningitis A vaccine is very important for college students,
Yes.
as well as people who are having sex without condoms. So our gay and bisexual patients who are on PrEP or who aren't on PrEP, and also our HIV patients. I recommend that we vaccinate them for meningococcal disease
Agreed.
with the meningitis A shot. And meningitis B shot, from what I understand, is very difficult to get covered by insurance. But if you can, I tell my patients if they can get it in some way, then get it, because meningitis B is an interesting vaccine because it actually confers 30% protection against Neisseria gonorrhea. So there's some cross-reactivity in the immunity of Neisseria meningitidis with Neisseria gonorrhea. So patients who get the meningitis B shot have about a 30% protection against gonorrhea.
No way.
Yeah.
Well, it's really good.
Yeah.
I did not know that.
Yeah.
Cool.
And then lastly, of course, in this day and age, it's important for us to talk about Mpox vaccine for our gay patients, because we had a big monkeypox scare a couple of years ago, and I think we did a great job in the Coachella Valley of rounding up our resources, depending on each other, even
And triaging
across
patients.
organizations, and coming up with a great vaccine campaign for our patients. I think an environment unique like Palm Springs, we were able to vaccinate a large mass of people, but we have to remember there's also a large mass of people who have not been vaccinated against Mpox.
Right.
And we think that Mpox is completely gone, but it's not. We're not getting the rates of infection that we were getting a year ago, but there are still some sporadic infections going on. So I still think it's important for patients to get vaccinated against Mpox.
I agree. Very much. Okay, so there you have it. I think we covered a lot of different things like STD screening, prevention, and treatment. The importance of detailed sexual history. We also talked about colon and prostate cancer screening, as well as lung cancer screening based on risk. And also screening for diabetes, hypertension, and cardiovascular disease. So we hope that this episode has provided valuable insight into men's health. Thank you very much for joining us today. And remember, your health should be a top priority. It is important to seek appropriate screenings and vaccinations and consult with your healthcare team. Dr. Adams, anything to add?
Well, if you use it, swab it.
Okay, so there you have it. Please like, share, and subscribe to our channel for future episodes. And for more information about us or what Desert Oasis offers our community, be sure to visit our website at mydohc.com. Until next time, take care of yourself and stay healthy. Happy Pride Month.
That's for Brad.
Let's do it again.
We should do like a Michael J.